Good morning and welcome to the Department of Medicine Grand Rounds. I will start with the land acknowledgement. I want to acknowledge that I'm situated upon the traditional territories of the Haudenosaunee and Mississaugas. This land is covered by the dish with one spoon, one pond agreement between the Haudenosaunee and Anishinaabeg, and all of us in this land to share the care for the resources around the Great Lakes. I know this is a virtual event, so wherever you are, please take a moment and acknowledge the people who were before us, who took care of the land we are in right now. So this is a combined grand rounds. We have our colleagues from St. Joe's Hospital, as well as from Hamilton Health Sciences and Department of Medicine. This is also a hybrid event where we have colleagues at St. Joe's who will come in later in the grand rounds, as they are in person at St. Joe's, and many of us are virtual today. I'm pleased to have today Dr. Zandi, who's going to speak to us in this grand round. Shervin has completed his medical school at McMaster University and his GIM training at University of Toronto. He started his practice at St. Catherine's, and now he's established an internal medicine outpatient practice at Grimsby, and does a fabulous job in covering internal medicine at West Lincoln Memorial Hospital, as well as on the medicine units at Dzierżawski Hospital. He is also part of the perioperative service. He has interest in perioperative medicine, cardiovascular medicine, and medical education. Shervin is gonna be speaking to us today about, Shervin, do you want to show your slides? Please go ahead. Introduce your topic. So Shervin is going to be speaking to us today on a review of expanding the roles of SGLT2 inhibitors. So as usual, Shervin is going to go through the grand rounds, and then at the end we will have a time for a Q&A session. Please write your questions in the Q&A, and we'll moderate them at the end. Without further ado, Shervin, please go ahead.
Perfect. Thank you very much, Dr. Azam, for those kind words. So I'm going to be presenting on the expanding roles of SGLT2 inhibitors, as I see it from a general internist whose practice in Grimsby involves seeing a lot of cardiovascular patients, as well as patients with diabetes. I do not have any conflicts of interest. The outline of the presentation will be as follows. I'm going to be talking briefly about the mechanism of action. I'm going to be providing 3 clinical vignettes with questions for each, which we will take up as the presentation goes on. The presentation is subdivided into 3 main headings, which include SGLT2 inhibitors in the setting of diabetes, heart failure, and CKD. I'm also going to be having a brief slide on some special considerations, and then we will have some time for questions thereafter. Basically, the way SGLT2 inhibitors work is we have an SGLT2 co-transporter on the tubular side of the proximal convoluted tubule. By blocking this SGLT2, which is mostly found in the proximal tubule, as opposed to SGLT1s, which can be found in the gut as well as the distal convoluted tubule. We're basically blocking any glucose reabsorption back into the interstitium and subsequently back into the bloodstream, as well as blocking sodium. This essentially will cause an osmotic diuresis as well as a natriuresis, leading to decreased plasma volume and blood pressure. This subsequently leads to decreased preload and afterload with improvements in cardiac function, and essentially also decreases glomerular filtration pressure, which, as we will see, can help in the management of chronic kidney disease. Through all of these things, it can decrease hemoglobin A1C, blood pressure, as well as weight, as you get approximately 100 grams of glucose excretion per day, leading to negative caloric balance. Clinical vignette number 1, we have a 67-year-old female who's been referred to your office for diabetic care optimization. She has a history of a TIA, type 2 diabetes, hypertension, dyslipidemia, and obesity. She's on medical therapy with aspirin, full dose metformin/sitagliptin, as well as atorvastatin and ramipril. She is a non-smoker. In your office, she's slightly hypertensive with a blood pressure of 140/70. Her BMI is 30. Her latest hemoglobin A1C remains elevated at 8%, with at target LDL, normal renal function, but with an elevated urine ACR at 50 milligrams per millimole. And all these levels have been stable for the past 6 months. She is interested in improving her hemoglobin A1C, even if it means adjusting her medications. What would we do next? These are a few options. No changes, see them in 6 months. We'll add both long-acting and short-acting insulin, add empagliflozin or gliclazide MR. Clinical vignette number 2, we're now seeing a 58-year-old male in the office. He was admitted to the hospital 2 weeks ago with new onset congestive heart failure. He was found to be hemodynamically stable but volume overloaded. He had an ejection fraction of 30% with no wall motion abnormalities. His BNP was elevated at 2000. He had minimal coronary artery disease on the angiogram, and he has had no recent infection or vaccination. He has a history of hypertension and obstructive sleep apnea on CPAP and works at the FASCO, so he does have drug coverage if needed. He was on perindopril before hospitalization, and now upon discharge, he was sent home on aspirin, perindopril, bisoprolol, atorvastatin, and furosemide. In your office now, 2 weeks after hospitalization, he remains hypertensive with a blood pressure of 150/95 with a heart rate of 60, and his CBC, potassium, and creatinine are all stable with a normal hemoglobin A1C, and his LDL is 2. So what would we potentially offer this patient? We could switch him from perindopril to Entresto, aspirin or lactone, add dapagliflozin, or all of the above, and we'll go through those answers later. And third vignette, we have a 7-year-old female who's referred to your clinic with new onset diagnosis of chronic kidney disease. These levels have been stable over the past few months. She had recently moved to Canada, and she has not had any previous medical care in the past 10 years. She doesn't have any known past history. She's a retired professor. She was not on any medications. She comes to the office. There's nothing on history to suggest any lupus or vasculitis. Her BMI is 27. She's hypertensive at 160/90. She has a creatinine of 120, giving her an eGFR of approximately 55, and her hemoglobin A1C is 8.5% with an LDL of 4. Her SPEP is normal, and her urine ACR is elevated at 100 milligrams per millimole. So you start her on metformin, telmisartan, and rosuvastatin, and you're wondering whether you should add anything else. So you're considering adding semaglutide, canagliflozin, spironolactone, or potentially A and B. So I'm going to be talking about 3 articles in regards to SGLT2 inhibitors in the setting of diabetes. By no means is this presentation an exhaustive list of all trials involving SGLT2 inhibitors. So I've just chosen the ones that I thought had high impact with medications that are available in Canada. As I go through these next 3 articles, I will note that the regulatory agencies in the last few years have mandated that any new medications for the treatment of type 2 diabetes needs to ensure that it is cardiovascularly safe, and this was in the setting of previous issues with rosiglitazone and pioglitazone with heart failure. And so the first study that we'll talk about is the MPAD-REG outcome, which is published in the New England Journal of Medicine in 2015. It was a randomized double-blind placebo-controlled trial with 3 arms, including MPAG-10, 25, and placebo. All patients had to have type 2 diabetes with a BMI of 45 or less and an eGFR of at least 30. Of note, all patients in this study had established cardiovascular disease. As part of the trial, they wanted to maintain a stable regimen of glucose-lowering treatment for 12 weeks after randomization. The primary outcome was a composite of death from cardiovascular causes, non-fatal MI, and non-fatal stroke, which we will see multiple times today, with key secondary outcomes, including the primary outcome plus hospitalization. For safety monitoring, they monitor for hypoglycemia, urinary tract infections, and general infections, volume depletion, AKI, bone fractures, DKA, and venous thromboembolic disease. As I mentioned, given the history of diabetic trials, the primary hypothesis was to ensure that there was non-inferiority with a margin of 1.3 for the hazard ratio. And if they achieved non-inferiority for primary or secondary outcomes, then they would look at superiority for the same outcomes. So briefly looking at the outcomes here, we can see that the primary outcome was composite of death from cardiovascular causes, non-fatal MI, and non-fatal stroke. And we can see that very early on from the trial beginning, you can see a moving away of the lines and with the statistically significant for superiority for the primary outcome, as well as death from cardiovascular causes, death from any cause, as well as hospitalization for heart failure. When we look at table 1 from the trial, again, we see that from the primary outcome, first they proved non-inferiority, and then they proved superiority. And the other things I'll bring us on this table is the same things we saw on the previous slide, which are death from any cause and cardiovascular causes, as well as hospitalization for heart failure. In terms of adverse events, a major key point to consider with using any of our SGLT2 inhibitors is the increased risk of general infections, both in male and female patients. And in this trial, at least, they did not see anything else in terms of side effects, including any evidence of DKA, which we know it does exist in clinical practice. Something to note for the future trials we're going to be talking about, they did not find any difference between the 2 doses of empagliflozin, 10 or 25 milligrams for cardiovascular outcomes. The hemoglobin A1C lowering was modest at negative 0.54 with empagliflozin 10 and negative 0.6 for 25. It was associated with small reductions in weight, systolic and diastolic pressures, as well as some small increases in LDL and HDL. As I said, general infections were higher with no other issues in terms of other side effects. Next trial is the CANVAS trial comparing canagliflozin and placebo. This was published in 2017 in the New England Journal of Medicine. This was a combination of 2 sister trials that were analyzed together, CANVAS and CANVAS-R for renal. It was again randomized, double-blind, placebo-controlled. There were 2 basic populations that they could enroll. One of them were people who had symptomatic cardiovascular disease and they were 30 years of age or older with a diagnosis of diabetes, or they could have had risk factors. They were a bit older. They had to be 50 years of age, and they would have had to have 2 risk factors, including diabetes for more than 10 years, ongoing hypertension, smoking, albuminuria, or an HDL of less than 1. And again, all patients had to have an eGFR greater than 30 in this trial. Approximately 65% of patients had established cardiovascular disease. It was a 1-to-1 randomization. The primary outcome, again, was a composite of death from cardiovascular causes, non-fatal MI, and non-fatal stroke, with multiple secondary outcomes that were sequentially looked at for hypothesis testing. And if one of them were not to be superior, then they would stop testing them. And then there were also some extra exploratory outcomes, which included a renal composite outcome, which will be important as we go forward. The safety outcomes were all of the above, in addition to bone fractures and amputations. And again, initially they had to prove non-inferiority before they could look into superiority. So in this trial, again, we see some of the cardiovascular numbers here. The hemoglobin A1C did drop significantly at the beginning of the trial and then started to get closer to placebo. There was a significant, statistically significant decrease in weight, as well as systolic and diastolic blood pressure. As we can see from this figure, the composite decrease in cardiovascular deaths from cardiovascular causes, non-fatal MI and non-fatal stroke were statistically significant. However, none of the individual components of those were. And something that I will bring our attention to as we move on later in the presentation is that if we start subdividing the patients in these trials into people who had cardiovascular disease established versus had risk factors for cardiovascular disease, we start seeing a difference in terms of what is statistically significant. So in this trial, if people had established cardiovascular disease, the composite endpoint was statistically significant. However, it was not for patients who did not have established cardiovascular disease. Some of the secondary outcomes, we did notice a statistically significant decrease in hospitalization for heart failure. However, no difference for death from any cause. But if you look at C and D, you see that from a renal perspective, there was statistically significant decrease in progression of albuminuria, as well as the composite renal outcome in D. From an adverse event perspective, the main thing to look at here is that in Canvas and only in this trial was there a significant increase in the risk of amputation, and particularly amputations of the toes and the midfoot, as well as increased risk of infections in the genitalia, as well as evidence of volume depletion and mitotic infections in women. Moving on to our third trial in this section, I'm going to be talking about the dapagliflozin and cardiovascular outcomes in type 2 diabetes, which was published in the New England Journal in 2019. Again, this was a randomized double-blind placebo-controlled trial. The inclusion criteria, again, were either people who had established cardiovascular disease, were over the age of 40 with diabetes and an eGFR greater than 60 in this trial, or people who had risk factors and are older, men over 55 or females are over 60, with at least one additional risk factor, including hypertension, an LDL greater than 3.36, or being on a statin and tobacco use. This was a one-to-one randomization. Again, similar to the previous two trials we just talked about, they needed to show non-inferiority first. The primary efficacy outcomes included MACE, as well as a composite of cardiovascular death and hospitalization for heart failure. And then they had secondary efficacy outcomes, including the renal composite outcome, as well as death from any cause. And then they looked at safety assessments, including all of the above, plus amputations, fractures, volume depletion, DKA, and general infections. From this trial, the effects on cardiovascular risk factors favoring dapagliflozin showed a modest decrease in hemoglobin A1C, weight, systolic and diastolic blood pressure. Looking at the major outcomes, we see that there was a statistically significant lowering risk of cardiovascular death or hospitalization for heart failure, as well as renal outcomes. However, there was no statistically significant differences in MACE or death from any cause. And when we further subdivide the primary outcome of cardiovascular deaths or hospitalizations, we see that it is mostly being driven by hospitalizations for heart failure as opposed to death from any cause. And we see a significant improvement in the renal outcomes in this trial, which will lead us to further investigations going forward. As I mentioned, if we were to subdivide the patients between people who had established atherosclerotic and cardiovascular disease versus multiple risk factors, we see that we're starting to see who really are the patients who benefit from this medication. There was a significant increase in patients who had diabetic ketoacidosis in this trial. And when you look at the actual patients who had DKA, about 80% of those were patients who were also on insulin at that time. So those are particularly high-risk patients that we need to educate on the risk of DKA. Again, there was increased risk of genital infections. And then there was also an increased risk of bladder cancer in this trial, which was not seen in the other trials in diabetes with SGLT2 inhibitors. So basically took you through the three main trials in SGLT2 inhibitors in diabetes. And I will briefly just go through a meta-analysis, just putting all three of them together. The overall findings of this meta-analysis was that all three medications had modest effects on A1C, weight, and blood pressure control. And the effect of the composite of MI, stroke, or cardiovascular death was driven by patients with established cardiovascular disease. And the effect on hospitalization for heart failure was regardless of whether the patients had heart failure before or not, which is important as we move on to the next set of trials. And the effects on the renal benefits seem to be stronger for patients who actually had better renal function at baseline. So these were the three trials, quite a few participants in all of them. In the EMPA-REG trial, all patients had established cardiovascular disease, whereas the Canvas and DECLARE-TIMI 58 had both patients with risk factors and with established cardiovascular disease. Only about 10 to 15% of patients had a history of heart failure, and patients who had moderate renal dysfunction composed only a small minority of the patients in this trial. So as I mentioned here, in terms of the composite of myocardial infarction, stroke, and cardiovascular death, we see that patients who had established atherosclerotic disease had a significant reduction in the hazard ratio favoring treatment with SGLT2 inhibitors, whereas patients with multiple risk factors did not. And then same with hospitalization for heart failure and cardiovascular death. Again, patients who had established atherosclerotic disease gain more benefit compared to people with multiple risk factors. Just for those who are a bit more visual like myself, when you look into the composite of renal function, end-stage renal disease, or renal death, we see that patients who had better renal function at baseline had significant improvement in their outcomes for renal causes, as opposed to people who had worse renal functions, albeit all of them had benefit. And we see a sort of opposite effect with hospitalization for heart failure, in that the worse the renal function is, the better the outcomes are, likely as they derive increased benefit from the diuretic effect of the SGLT2 inhibitors. By no means is this a full conversation about how we're going to manage our patients with diabetes, but just to bring us to the Diabetes Canada updated guidelines from 2020, you can see that if the A1C is not a target, and if they have established cardiovascular disease, CKD, or heart failure, or if they're older with multiple risk factors, we can't just worry about the hemoglobin A1C anymore. We actually have to be more targeted in our approach to treatment, with the thought that we initially start with metformin and then we add secondary agents. And so in patients with established cardiovascular disease, who you want to lower the risk of MACE, hospitalization, or nephropathy, SGLT2 inhibitors are your friend. Same with CKD, as well as heart failure. So taking us back to the first clinical vignette, the 67-year-old female who came to your office for diabetic care optimization, who still had a hemoglobin A1C of 8%. She was still hypertensive, and she had normal renal function. She was already on aspirin, metformin, sitagliptin, as well as atorvastatin and ramipril. What would you be doing next? Option A, I think, is not appropriate, given that we know that from Diabetes Canada, we want to reach hemoglobin A1C targets as quickly as possible, hopefully within 3 to 6 months. And so if we don't do anything, we won't be achieving much. I think that adding insulin to JO and Novo Rapid is not ideal in this situation. Certainly it could help with the hemoglobin A1C, but it would not help necessarily with decreasing this patient's cardiovascular risk, given that she had a TI in 2018. And therefore, I think that empagliflozin would be the ideal choice, as opposed to glycoside as well, which has not been shown to have cardiovascular benefits. So moving to heart failure with SGLT2 inhibitors, I'm again going to briefly review 3 articles here, DAPA-HF, Emperor Reduced, and Emperor Preserved. And the reason that they went through the trouble of making these trials is that, as we saw initially, only about 10 to 15% of patients in the previous three trials had established heart failure. So those trials really tell us, in patients who essentially the majority of patients did not have heart failure, are we going to be able to prevent heart failure exacerbations de novo? Whereas in these trials, we have patients who have known congestive heart failure, and can we reduce cardiovascular outcomes? So DAPA-HF published in the New England Journal in 2019, placebo-controlled trial, double-blinded and randomized. The inclusion criteria were patients who were 18 or over, an ejection fraction of less than 40% with NYHA 2 to 4 symptoms. And in order to try to make them even higher risk, they wanted to make sure that the BNP was elevated to above 600, or only 400 if they had been hospitalized for heart failure within the last 12 months, because that is a risk factor for recurrent hospitalizations, or if they had atrial fibrillation or flutter, the BNP had to be greater than 900. Patients were on standard heart failure therapy, including devices if needed. The only one note that I will say is that MRAs such as spironolactone or Pleuronone were only recommended. The exclusion criteria for this trial were people who've had side effects to SGLT2 inhibitors, type 1 diabetics, or people who were already hypotensive or had a GFR of less than 30. They were randomized to 1-to-1 to dapagliflozin or placebo, and the primary outcome was a composite of worsening heart failure or death from cardiovascular causes. They have secondary outcomes, including the total number of hospitalizations, deaths, and change in the Kansas City Cardiomyopathy Questionnaire, as well as worsening renal function or renal death. They looked at the similar safety analysis, including volume depletion, hypoglycemic events, bone fractures, DKAs, amputations, as well as Fournier's gangrene. Of note in this trial, about 42% of patients had diabetes, and 99% of patients in each arm had NYHA class 2 to 3 symptoms, and this will play again and again in the other trials as well. So the primary outcome, which was the composite, was statistically significantly better with the dapagliflozin group, with the number needed to treat of only 21. And as you can see, hospitalizations, as well as death from cardiovascular causes and death from any cause were statistically significant to be better with DAPA as opposed to placebo. These results were consistent across multiple variables, including patients with and without type 2 diabetes. The only thing that I will mention here is that patients who were on ARNI or sacubitril valsartan or Entresto did not derive as much benefit with dapagliflozin, and this was just seen in this one trial. Primary outcome, significant improvement, as well as secondary outcomes, as I have mentioned before. And then looking here at some adverse events of special interest, or some of the variables that we see here, we see that the hemoglobin A1C slightly decreased, and there was also a decrease in BNP, weight, and systolic blood pressure. Moving on to EMPEROR-reduced trial. This was published in the New England Journal in 2020, looking at empagliflozin in cardiovascular and renal outcomes in patients with heart failure and reduced ejection fraction. 3,730 patients, randomized 1-to-1 to empagliflozin 10, as opposed to 25, as the previous trial with EMPACT showed that the cardiovascular outcomes were essentially the same between 10 and 25. Again, 18 plus, NYHA 2 to 4, EF of less than 40% on adequate treatment. And again, they're trying to increase how risky these patients are by trying to offset any rise in the ejection fraction with an increase in the BNP. As we know, BNP is a risk factor for poor outcomes in patients with heart failure. All of these thresholds were increased with patients who had atrial fibrillation, and the primary outcome was composite of cardiovascular death or hospitalization for heart failure, with secondary outcomes now looking as well as renal function. About 50% of patients in this trial had type 2 diabetes, and again, only about 0.5% of them had NYHA class 4 symptoms. What we see from EMPEROR-reduced is a significant improvement in the primary composite outcome, mainly being driven by hospitalization for heart failure as opposed to cardiovascular death. It did, however, decrease the total number of hospitalizations as well as slow down the progression of kidney disease. And again, a very significant improvement in composite renal outcome with empagliflozin 10 in this trial. Here I'm just showing you the GFR change in this trial. As we can expect with any of the SGLT2 inhibitors, we do get initial decrease in the GFR, similar to what we see with ACE inhibitors or ARBs. However, if you look at it more long-term in the trial, you see that there's a flatter slope with SGLT2 inhibitor, which shows that there is a slow decline in renal function as opposed to placebo. And this was a big trial when it came out earlier this year, the Emperor Preserved trial. We don't have a lot of positive trials in heart failure with preserved ejection fraction, and so this was a bit of a banger in the summer, and so we'll go through it as well. So this was a double-blind placebo-controlled trial of almost 6,000 patients. Again, they were over the age of 18 and NYHA class 2 to 4 with an ejection fraction of 40%, but with elevated BNP. One-to-one randomization with a primary outcome of composite of cardiovascular death or hospitalization for heart failure, as well as secondary outcomes, including the declining GFR. Again, in this trial, about 50% of patients had type 2 diabetes, about 50% of patients had an eGFR of less than 60, and about 2/3 of patients had an ejection fraction of greater than 50%. And again, very few patients in NYHA class 4. So what we can see from the primary outcome is that there is a statistically significant decrease in the composite of cardiovascular death and hospitalization, favoring empagliflozin. However, when we take a look at the individual components of the composite, we see that this is again being driven mostly by a decrease in the hospitalization for heart failure and total hospitalizations for heart failure. And as we can see here, the renal function improves or does not decline as quickly, and that is statistically significant in favor of empagliflozin. So briefly, just going through the one slide of the new Canadian Cardiovascular Society guidelines in heart failure with reduced ejection fraction. We see that the new guidelines have included SGLT2 inhibitors as part of the initial bundle of care, which includes ARNI over top of ACE inhibitors or instead of ACE inhibitors or ARBs, as well as beta blockers and MRAs. From my own experience, I find it difficult to start patients on all four all at the same time. However, you can choose to go low doses for all agents and slowly up titrate or go one agent at a time. The guidelines recommend either. So let's go back to our clinical vignette number 2. This was our 58-year-old male who was admitted to the hospital 2 weeks before with an ejection fraction of 30%, elevated BNP, minimal coronary disease, and he had already been started on perindopril, aspirin, bisoprolol, atorvastatin, and furosemide. He remains hypertensive in your office with normal lab work, and so changes that we can consider were changing perindopril to Entresto, adding spironolactone, which is an MRA, as well as adding dapagliflozin. And I would suggest that doing all of the above is likely in the best interest of the patient. However, you can choose to do them all at the exact same time or doing them sequentially as long as the patient has good follow-up with renal monitoring. Moving on to the next part of our talk is the SGLT2 inhibitors in the treatment of chronic kidney disease. Here, so far, the only 2 trials that are available are Credence and DAPA-CKD. There is a trial underway for empagliflozin as well, but it's not yet available to review. So Credence was testing canagliflozin with renal outcomes and was published in 2019. Again, a double-blind placebo-controlled trial of 4,400 patients. They were all over the age of 30, diabetic with an eGFR between 30 and 90. And one of the things that initially struck me was that just be mindful of the urine ACR numbers in the trials. They were in milligrams per gram, whereas in Canada we use milligrams per millimole. So I just switched those to our numbers just for so we can just remember better from our own patients. Patients who were suspected of having non-diabetic kidney disease or type 1 diabetes were excluded, as well as patients who had been treated with immunosuppression or had a history of dialysis or kidney transplant. It was a 1-to-1 randomization to canagliflozin 100 with the ability to increase to 300. The primary outcome was end-stage kidney disease, which they defined as 30 days of dialysis, kidney transplant, or a sustained eGFR of less than 15 for 30 days, doubling of serum creatinine, death or from renal or cardiovascular causes. And they had a slew of secondary outcomes, which I've just listed here. For safety evaluation, it was all of the above, plus again, fractures, pancreatitis, ketoacidosis, and renal cell carcinoma. The trial was ended early as it had reached pre-specified efficacy criteria. And so when we go through the primary composite outcome, which I laid out in the previous slide, we see a significant improvement with canagliflozin, with the number needed to treat impressive at only 22. And then when we look at the secondary outcomes, we see that cardiovascular death, MI, or stroke, as well as hospitalization for heart failure, were statistically significant, with numbers needed to treat of 40 and 46 respectively. In terms of efficacy, if we remember with the Canvas trial, there had been an increased risk of amputation with canagliflozin. This has not been seen with other SGLT2 inhibitors, and interestingly, it was not seen with canagliflozin in this trial either. So that's just something to keep in the back of our mind. And if we take a look at the renal parameters here, the urine ACR, we see a significant early improvement with canagliflozin, which is sustained. And similarly, how we saw with the other trial, we see a decrease in the GFR initially with SGLT2 inhibitor initiation. However, the rate of decline is much slower compared to placebo. And then DAPA-CKD, again, New England Journal getting all the praise today. This was published in 2020. Dapagliflozin in patients with chronic kidney disease, randomized double-blind placebo-controlled trial of 4,300 patients. GFR here was slightly different, 25 to 75. They had proteinuria, and they were stable on ACE or ARB for at least 4 weeks. Of note, in this trial, not all patients had diabetes. In the credence trial, they did. Some of the exclusion criteria were type 1 diabetic, polycystic kidney disease, lupus nephritis, ANCA-associated vasculitis, as well as people on immunotherapy within 6 months of enrollment. 1-to-1 randomization to dapagliflozin or placebo, with a primary composite outcome being decline of 50% in GFR, end-stage kidney disease, transplantation, GFR of less than 15, or death from renal or cardiovascular causes. They had a number of secondary causes, which they did a hierarchical assessment. And then for safety monitoring, there was volume depletion, renal events, major hypoglycemia, bone fractures, amputations, and DKA. Again, another trial that was stopped early as it reached a predefined efficacy criteria. And of note, about 32.5% of patients did not have diabetes in this trial. Primary composite outcome, statistically significant in favor of dapagliflozin. Again, no difference in deaths from cardiovascular causes in this trial, but from a renal perspective, strong improvements in outcomes favoring dapagliflozin. And again, there was no change in risk of amputation in this trial. Similar graph that I've showed you before, initial decline in eGFR as expected, with a slower decline thereafter. And so taking us to our last vignette, we have a 70-year-old female with new onset CKD in the setting of type 2 diabetes with a hemoglobin A1C of 8.5%. She's also hypertensive with an eGFR approximately 55 with a urine ACR of 100. So she was started on metformin, telmisartan, and rosuvastatin. And what else could we consider? We could certainly consider semaglutide or Ozempic subcutaneously weekly for this patient. I didn't go through any of the GLP-1 trials here today, but there is decreased weight as well as cardiovascular benefits. However, when considering the renal outcomes, we know that canagliflozin has improvements as well. And so I would say that we could consider both A and B given that hemoglobin A1C is 8.5%, and I would not expect that the canagliflozin alone would be able to achieve a hemoglobin A1C, a target of 7. So the semaglutide may be able to help us there. So that was the review of the trials. Some special considerations to have. There's definitely an increased risk of GU infections in these patients. They were not noted to be bacterial UTIs. More often, they were just fungal infections, but still, just be mindful of patients who have recurrent UTIs, just to make sure they don't get worse with SGLT2 treatment. And be especially cautious of bedbound patients or very obese patients who may not have as good hygiene, and be mindful of the possibility of Fournier's gangrene. The trials have shown some increased risk of bone fractures, so just be cautious in patients who have osteoporosis, or consider getting bone mineral density testing prior. These patients can develop hypotension, and we did see some definitely osmotic diuresis. And so in patients who are already on diuretics like hydrochlorothiazide or furosemide, for example, you can consider decreasing those doses simultaneously as you start your patients on treatment. Definite risk of diabetic ketoacidosis, and in particular, euglycemic diabetic ketoacidosis. So loss of patient education. I think that there has been significant education in the community about looking for euglycemic DKA, and certainly we need to do more of that. Very important to be checking with venous gases as well as serum ketones, as the glucose could be normal, as I mentioned. And then in terms of risk of amputations, this was only seen on the Canvas trial, but it doesn't hurt to take your patient's shoes off in the office just to ensure that there's no risk of amputation or ulceration already. And just a little bit of a plug for perioperative considerations. So the perioperative setting is marked by several physiological changes, including dehydration, as patients are often fasting, they have limited oral intake, and there's increased metabolic demand predisposing to a ketogenic state. There's also a catecholamine release prompting increased gluconeogenesis, lipolysis, and ketogenesis. Throw in an SGLT2 inhibitor in there, which increases glucagon synthesis, lipolysis, ketogenesis, as well as increased renal reabsorption of ketones, and you can find yourself in trouble. A lot of the symptoms of DKA are similar to symptoms that you would expect in postoperative patients, including nonspecific nausea, vomiting, abdominal pain, as well as tachypnea and altered level of consciousness. And so again, we have to be very mindful of monitoring with venous gases and ketones. There are no consensus guidelines. In speaking with our own perioperative group, we are recommending stopping SGLT2 inhibitors for 48 hours prior to the OR and initiation only after they're taking a full diet. Just a question to myself was, could this lead to an increased risk of heart failure exacerbations in the perioperative setting, given the improvement in heart failure with SGLT2 inhibitors? So that was it from my presentation. I hope I didn't rumble along too much, and that this was helpful for both general practitioners, general internists like myself, as well as the subspecialists that we all work together.
Shervin, thank you very much for this comprehensive review and the cute picture at the end, So bringing in the group from St. Joe's with Dr. Verhofsik, if they have any question, but we do also have some questions from the Q&A. So there's a comment from Dr. Priptani about the efficacy of SGLT2 inhibitors with reduced creatinine function to control blood sugar while continue to have benefits from cardiovascular and renal effects. So do you want to comment on that at all? Or I don't know if,
yes, I mean, I think Dr. Priptani knows this topic much better than I do, and I agree that the A1C lowering reduction is minimal, and I think SGLT2 inhibitors will definitely revolutionize the treatment for our cardiovascular patients in general, as opposed to just our diabetic patients.
Madeline, I'm not sure if you have any question from your side. If you do, please unmute and ask your question as we're going through the questions from the
we have one question. You can just push that.
Okay, go ahead.
Hi, this is Keon. I'm just wondering about your last, thank you for the talk, by the way, it was great. With regard to perioperative patients, when we're admitting patients overnight, or seeing perioperative patients overnight, would you stop SGLT2 inhibitors generally, just regarding your last slide?
Thank you for your question, Kian. I would say that if the patient is acutely ill and whether they're going to go for surgery or not, I think the safer thing to do would be to stop SGLT2 inhibitors. As I mentioned, these patients are at an increased catabolic state and ketogenesis, and so if their sugars are up a little bit, you could always deal with that on a timely basis. But you wouldn't want them to go into DKA just before their operation and increase their risk.
Thank you.
Thanks, Shervin. And there's actually another question asking about the blanket decision in some hospitals, not ours, I believe, that just to hold the SGLT2 inhibitors if a patient's acutely ill and admitted. I know many of us do, but what are your comments on that?
Yeah, well, thank you for that question. I mean, I think we need to have a little bit of a wiggle room for individual decision making. If the patient is being admitted with a heart failure exacerbation and they're otherwise hemodynamically stable, I think those patients I would probably continue the SGLT2 inhibitors. If they're coming in with other issues such as pneumonia or definitely a urinary tract infection, for example, I think it would be reasonable to stop.
Good segue to the next question, which is from Dr. Dorsami about what's the pathophysiology, like a pathophysiological basis of the urogenital infection in SGLT2 inhibitors.
Sure. Thank you for the question, Dr. Dorsami. I don't know the exact answer to that, but I believe that it probably has to do with the increased glucosuria, which can then increase the risk of fungal infections. I think we also have to be cautious and continue to have long-term studies on potential increased risk of GU malignancies as well in these patients. And so I think that is probably the pathophysiological basis, but why it doesn't increase risk of UTI, but yes, for fungal infections, I am not sure.
Very interesting. If anyone has a question that they would like to bring up in person or want to speak up or have a comment, please raise your hand and I'll bring you in. Madeline, do you have any other question from your site?
No other questions here at the moment, but thank you.
Okay, fantastic. We're just gonna carry on with the question from the Q&A. And so there's a question about this euglycemic decay. It continues to be an enigma, right? And so question is about the outcomes of euglycemic decay, and knowing that hyperglycemic DKA has a bad outcome, high mortality. What about euglycemic DKA? Do you know much about that?
Thank you for the question, Dr. Klaas. I don't know whether there are less risky patients in terms of risk of death. I've had dealt with a couple of myself at West Lincoln, and I think my general sense is that they tend to present later in their illness just because they're at home checking their sugars, they don't see any issues, they come to the emerge, they're tachypnic, they think that they're just septic, and people just don't clue in yet. I think with better education and communication to primary practitioners in the community, we will hopefully be able to pick these patients up sooner. And because they're not hyperglycemic, I wonder whether they could be cardiovascularly better and not as dehydrated. But with the SGLT2 in place, they probably have been dehydrated as part of the treatment. So I suspect overall that they will probably end up having similar outcomes once we're able to pick these patients up sooner.
Cases I've seen end up looking a bit healthier than the ones which come with the hyperglycemic decay. They're much sicker, although they come mostly precipitated by an infection and things like this, pneumonias and others. But they don't look as sick, and that's why it becomes more difficult to look for it, and it does need that effort to look for these diagnoses and initiate treatment which is exactly the same as DKA treatment, so which is the hyperglycemic DKA. Back to the infection, urinary tract infection story. So a question about should we avoid the SGLT2 inhibitors, T2 inhibitors in patients with indwelling Foley catheters if that's an increased risk?
Yeah, I mean, great question. I don't know. I feel like I'm a running joke here. I don't know the answer to that question either, but I would think that as long as good Foley catheter care is provided and people are having good general perineal care, I think that it shouldn't be a strong contraindication. That being said, should we be looking into exchanging those Foley catheters more frequently as compared to once monthly, which is the usual for outpatient CCAC? I think I don't know.
Yeah, I think there's a comment from Dr. Pertani as well about the increased glucose in the genital area and genital hygiene being paramount importance to deal with this, which does sound like a big piece of this, as you've alluded, Shervin. So thank you. Other comment from Dr. Pertani is about euglycemic DKA, and actually I was going to ask that question is, once you have a euglycemic DKA on those medications, and would you restart? Because I've seen people say like, oh, never restarted again. And Ali, and I'm not sure if Ali wants to come in the conversation, saying like you should consider restarting those medications because we see the benefits from them. Shervin, what are your experience and thoughts on that?
Yeah, I mean, if there is an obvious precipitant that was unrelated to SGLT2 inhibitors, as far as we know, let's say pneumonia or something like that, I think it's reasonable to try to restart it. If I don't have a good reason, then I would speak with my patient and say, look, these are the benefits, these are the drawbacks. In the trials themselves, patients who had DKA were immediately stopped from having SGLT2 inhibitors, but obviously that's not a very practical thing to do in the community. So what I would do is if there's another obvious cause for their DKA that is easily reversible, then I would speak with them and consider resuming it as an outpatient.
Okay, looks like there is a question from St. Joe's. Nathan, then go ahead.
Hi, my name is Upkar. I'm a pharmacist. Just asking a question about SGLT2 inhibitor and starting. What is your lowest GFR you go by? Like I think in preserved ejection fraction, that trial, they went down up to 20 milli, but eGFR of 20. And that's one question. The other one is, where is your cutoff to stop the SGLT2 inhibitor? How far low you go?
Sure. So thank you for those questions. What I've been doing is, I just go on UpToDate and take a look to see what the cutoff values were for each of the trials and make sure that I am within those parameters, because each trial did use slightly different. Most of them were over 30, some of them were 25 to 75, some of them were over 60. In terms of when would you stop, I think that's a question that will probably continue to change in the answer as we're seeing these patients benefit from a renal protection. And so in the renal trials, they did continue the treatment even in patients who had GFRs that were below 30. And so I think the data at this point is not that strong, but I suspect that as we get more data for the renal benefits of SGLT2 inhibitors, we will see that even if they have decrease in their renal function, we would not stop the SGLT2 inhibitor.
Thank you. There is a hand up, from DF. I'm going to allow them to talk and see if you have a comment or question.
Oh, hi. Excuse my name. It's Steve Wong. I just typed it in randomly. I had a question coming back to the euglycemic DKA idea. So I've seen some people, if they're a type 2 diabetic who ends up having a euglycemic DKA on SGLT2, two camps have thought that now they're prone to DKA forever and we need to now put them on MDI insulin. And others who have felt, oh, well, it's just provoked by the SGLT2. Do you have a feeling on which direction you would take if a type 2 diabetic develops euglycemic DKA on SGLT2?
Thanks for the question. I mean, I think if there's no obvious precipitating cause for the euglycemic DKA in the type 2 diabetic patients, I would definitely speak with them and say, look, it seems like you are at higher risk of developing DKA, and I would consider stopping the SGLT2 inhibitor. That being said, patients with insulin as well are at increased risk of DKA. And so I think that overall, it's all about patient education, potentially sending them home with ketone strips, just to make sure that if they do get sick, that they can reach medical care urgently. I don't know if I answered your question, but sorry.
And there was another similar questions in the Q&A, so that's a really good approach. I'm gonna bring in Dr. Precautions. Ali, you can go ahead and speak.
Thanks, Khalid. Wonderful presentation, Shervin. Very practical and pragmatic approach. Just a couple of things, and we are seeing some of these patients who don't have a precipitant, but I agree that if they have a precipitant that's easily reversible, the benefit for the most of the cases outweighs the risk of restarting as an outpatient. So that's really important because the benefit is so huge. And just to keep in mind, some of these patients who are labeled as type 2 may in fact be type 1 who present with euglycemic DK. So keep that in mind that they may falsely be labeled as type 2, especially with the condition called LADA, latent autoimmune diabetes in adults. So just something to keep in mind that all type 2s are not really type 2s. They could be type 1s or something we used to call in the past as type 1.5s. And they obviously it would be contraindicated as per indications right now for SGLT2s to use them in type 1s.
That's a great comment.
Thank
Thanks, Ali. Also had a comment on the cutoff for the renal function, so and how it's renal protective. So thank you very much for that as well. No, I sometimes struggle with patients. You've mentioned Shervin, those who become hypotensive when you introduce SGLT2 T2 inhibitors, and I wonder about the balance between using diuretics, which we know don't have much benefit other than being diuresing, and maintaining those medications. With this, your first reaction to the patients like stop the thing that you've started last, which is usually one of those medications, right? So
yeah, so I see that often in new onset heart failure patients that present. I try to get them a bit more euvolemic initially, and then I do recommend to them to, let's say if they're on furosemide 40 and I'm going to start them on an SGLT2 inhibitor, I will bring their furosemide down to 20 milligrams for a couple of weeks, assess their renal function, and then consider stopping it. Because as you mentioned, these new medications do have sort of cardiovascular benefits, whereas furosemide is just more for volume control and symptom relief. So I think that we have to do a bit more education on that. I did present on heart failure to my group at West Lincoln last month, and again, trying to encourage this sort of transition from furosemide into some of the other agents that have shown mortality benefit, including SGLT2 inhibitors.
Fantastic. Thank you very much. This has been a really, really good overview. And I want to close, but there's a comment from Dr. Precautions. We're in the process of developing a simple tool how to use SGLT2 inhibitors and the health control. Thank you. I think we'll be looking forward to see those tools. Ali, will be great. I mean, we're at time right now, and thank you, Shervin, for this comprehensive review. I think, clearly from the interactivity at the end of your grand rounds, it tells us a lot about how important is this topic and this revolutionary drugs, really, which is reminds me of other drugs when they were discovered. It's probably in a bit we're gonna mix them with water, maybe not, but they appear to be beneficial for so many other things, but also have an array of side effects that we should be all aware of. So thank you very much for your presentation today, and thank you everyone for attending this morning, and you all have a great day.
Thank you very much, everyone.
Thanks, Shervin.
Thanks.
Have a good day.
Bye.